Hello, I'm Susan Slovin. I'm a medical oncologist from Memorial Sloan Kettering Cancer Center in New York City. I think everybody has to keep in mind that not every checkpoint inhibitor works for every solid tumor. When we first started out with anti-CTLA-4, our biggest concern was that its robust anti-tumor effect in melanoma was going to be equally applicable and effective in prostate cancer, and it wasn't. Nevertheless, we did have some very exceptional responders. So what's very interesting about that is prostate cancer has been really very suboptimal in its response to the checkpoint inhibitors. There have been some very unique responders to anti-PD-1 therapy with pembrolizumab, but also with anti-CTLA-4, which is really quite interesting. I can tell you about a gentleman who, interestingly, we did not have, when we first did the trial, we didn't have the technology to look at tumor mutational burden, nor did we have the opportunity to look for microsatellite high instability, among other concerns, including even polymorphisms in CTLA-4. Yet the patient who had an exceptionally high PSA in the thousands, received 4 cycles of anti-CTLA-4 and had a dramatic, if not profound, decline in his PSA to roughly 24. Now that's quite a decline. He did have some, I should preface it by saying this was a gentleman whose major sites of disease was recurrence after radiation therapy, and the recurrence had been radiation therapy for the prostate and had the recurrence in local regional lymph nodes along with disease in the prostate. He received CTLA-4, profound decline in the PSA, and interestingly, not only did the prostate shrink, but the lymph nodes completely disappeared. And he has enjoyed probably more than a 15-year response to therapy and keeps going with a PSA that is nadir to less than 0.05. In the retrospectoscope, after obtaining some of the original tissue, we did not find any of the indicators for response, meaning high mutational burden or genomic alterations, just the opposite. Again, nothing. And yet he was a unique responder. If you go back and look at a lot of the literature that's out there, there is a tail of the curve. So even in prostate cancer, for example, where the drug anti-CTLA-4 really did not show impact on survival, either in patients who were post-chemotherapy with docetaxel and the drug was given with radiation, or in the pre-chemotherapy clinical state, there seemed to be unique responders independent of all these predisposing factors that would allow for sensitivity to the drug. That tells me that there's something either very unique about prostate cancer, to be determined, of course, or that there are just some patients who, for reasons that still remain unclear to us, will have a durable response. Why prostate cancer is suboptimal in its response to the checkpoint inhibitors remains to be determined as well. And I have spent quite a bit of my career trying to find that out, but unfortunately we still don't understand the lack of robustness of this particular cancer to the checkpoint inhibitors. Again, reinforcing the concept that not every drug treats every cancer equally.